So when we talk about stroke prevention, I think it's important to really look at why do we really need to know more about atrial fibrillation as it pertains to the stroke, and how do we really risk stratify these people? What is the role of drugs, which is more of a systemic treatment? And then how do we really use devices for this particular problem on a more local level? And then what's the role of ablation, combinations of these things? And do we really need to be looking at primary prevention as a strategy? And then how do we really manage the expectations of people, of both your referring docs as well as the patients themselves? So with this, we're trying to make a connection between atrial fibrillation and stroke. Is atrial fibrillation really predictive of strokes and mortality? And how does the treatment of atrial fibrillation really remove that supposed increase in the risk of strokes? And how does the treatment really change the mortality paradigm? And what's the balance of benefit versus risk of treatment? So these are all important questions that come up. And with that, let's try to connect the dots between stroke and atrial fibrillation. I mean, this, I think for some of us that have been in the modern era, we have not really used the M mode, and I'm sure there are enough of you out there that still understand the M mode. And some of the very early elegant work that came out, both from the surgeons and pathologists, especially in the realm of the non-valvular, in the valvular atrial fibrillation group, where you have, we dealt with mitral valve diseases and aortic valve diseases, and you had all these pathological specimens you opened up and you looked at, and you were very surprised to see that there were clots, and perhaps that was some of the very early connections that we made, that people with valvular heart disease, and they also happen to have atrial fibrillation, which is mostly chronic. They all ended up having thrombi in their left atrium and the appendages and attached to the valves. And perhaps that was one of the early connections that we made, and how anticoagulation as a concept to treat valvular heart disease and prevent strokes really came into the clinical existence. Again, these are some very early images from 1979 showing the presence of a massive thrombus inside the left atrium, attached to the wall as well as the mitral annulus. Again, this is a pathologic specimen that started building up the case for why it is important to think of anticoagulation in patients with rheumatic valvular heart disease. So I think by 1960s, I would say maybe 1970s, the evidence was pretty clear that rheumatic heart disease, atrial fibrillation, and intracardiac thrombus and stroke all were linked to each other very well. But again, this very important piece of communication by Professor Miller-Fisher from Mass General to the Lancet actually paved the way for connecting the dots for non-valvular atrial fibrillation. In this very small, in this letter to the editor, where he reported about 7 people that were having arteriosclerotic disease with 4 rheumatic, and in their impression that he thinks that these people probably have strokes related to atrial fibrillation. So this is some very early work, and you're only talking about 1972, the year I was born. So that subsequently led to further observations where the Framingham study, which is a 30-year-old study, specifically looked at the incidence and the correlation of strokes and atrial fibrillation. For those people who have atrial fibrillation, the relative risk of stroke is 5 times more than those people who do not have atrial fibrillation. And that risk seemed to persist and get worse as you got older, really establishing the connection of non-valvular atrial fibrillation and stroke in a much bigger way. And then this sort of led to the theorization or the putative mechanism of stroke, where if you have atrial fibrillation, there should be loss of atrial contractility, and that loss of atrial contractility would result in stasis of blood, and that subsequently leads to left atrial thrombus, and most likely in the left atrial appendage, because that's a structure that is that has a relatively large surface area, nooks and crannies, and has the most ability to retain a clot if at all there is one that forms in it, and that could subsequently get embolized and result in a stroke. So with that, let's switch gears and try to understand the global burden of stroke in patients with atrial fibrillation as an epidemic. As we see here, The global prevalence of atrial fibrillation seems to be increasing, whether it is we got better at diagnosing these people with AFib, we have better access to medical care, or is there a natural change in the profile of the human beings with increasing body mass index, change in food, access to a lot of junk that we eat on a day-to-day basis with higher incidence of diabetes, hypertension, and everything else, or in developing nations where the access to good antibiotic therapy for rheumatic disease still seems to be a problem. So with that in mind, in the developed world, we also see that there is an increasing incidence of overall stroke and mortality related to this, even though we claim superior medical therapies and access to care in a lot of places. When you look at the CHATS-2 score, which is a risk stratification score that has increasingly becoming popular over the years, as the CHATS-2 score increases, our overall risk of stroke dramatically increases. When you move from 0 to 6, the incidence of stroke raises by about 16% per year. And a more, even more robust scoring system that takes into consideration the female gender, lower age, and vascular disease, it also shows a very similar trends to that of the CHATS-2 score, where increasing CHATS-VAS score does result in increasing overall risk of stroke. So this is a nice summary slide from the European Society of Cardiology, where this shows the regional differences in the incidence of strokes. But if you really correct it to the hypertension, heart failure, and a variety of other factors, this differences seems to really pan out a little bit. And also rheumatic fever seems to play a much bigger role. So the fundamental difference in the type of arrhythmia or the underlying structural heart disease really makes a big difference. The Western world dealing with more of a non-valvular atrial fibrillation, and the Eastern world and the developing world dealing with more of a valvular heart disease as a major underlying cause. And there are some obvious differences in how we tackle this. So oral anticoagulation for stroke prevention atrial fibrillation. This is a very old concept. It seems to be old, but it's really not that old. When you look at the warfarin, the Wisconsin Alumni Research Foundation drug that was originally approved in 1952 for systemic oral anticoagulation, didn't really take off up until the late 1990s, when actually some of the pioneering work in stroke trials in using warfarin as an agent really came out. And study after study, there is a consistent reduction in strokes compared to a placebo or aspirin, clearly establishing warfarin as an important therapeutic armament in people with atrial fibrillation and in reducing the overall incidence of systemic thromboembolization, strokes, and mortalities. So the same data, if you really put it in a different form, it really results in a dramatic reduction of all the targeted endpoints. But funny enough, most of these trials did not really have those big numbers that we see in some of the mega trials that we come across in the world of novel oral anticoagulants, which we'll be looking at in a few minutes. So when you have a target INR of 1.8 to 4.2, all the pooled randomized controlled trials shows an absolute reduction of 3.1% per year. And 3.1% doesn't really look to be very big, but when you sort of extrapolate it to millions of population that are out there, that's a massive number. And some of the most current trials actually show even as high as 8.4% when you really have the whole the Coumadin regimen figured out and you implement it in a more rigorous fashion. So the overall risk of intracranial hemorrhage also goes up. This could be anywhere between 0.2 to 0.3% per year. Again, this is not a trivial number when you really take into consideration the global populations. So by 2000s, I think different combinations of INRs, combinations of variable INRs and antiplatelet agents, they all became very fashionable to check it. I mean, somebody proposed a theory of how about INR that is just below 2 using an aspirin. Those things don't seem to work. I think to really keep them in a therapeutic range of 2 to 3 makes the absolute sense, and that actually has, as it is shown in this particular curve here, has the absolute benefit from overall embolic risk versus the risk of intracranial hemorrhages can be mitigated if you stay in the therapeutic regimen of 2 to 3. So this nice JAMA Internal Medicine paper from 2013 clearly shows, since 1992, the usage of Coumadin has significantly improved. In fact, we almost reached a plateau by 2002, by which time most of the major anticoagulant trials have already been done, with a significant improvement in stroke risk and also the accepted risk of hemorrhagic strokes that come from the usage of these medications. I think we as a medical community have done a fantastic job in taking Coumadin to people and sending the message across, and that number seems to get better. So with these regional differences in crude stroke rates being taken into consideration, with Africa and Asia still leading the path, what explains those differences? When we adjust these for hypertension and diabetes and relook at them, perhaps the adjusted stroke rates are not really that different amongst countries. And is there a role for primary prevention of stroke and atrial fibrillation here? That's, I think, for a much bigger topic to discuss about, that really opens up a lot of avenues that we should be actively looking at rather than treating the back end of it. So when we look at Coumadin per se, how many people are really protected by warfarin? So 50% at-risk population is eligible for anticoagulation. Of those, 35% actually get warfarin. This supposedly is a statistic that was derived on some of the surveys. And of the warfarin-treated patients, if you assume that 65% therapeutic time in therapeutic range, that's actually a pretty ambitious number, right? So how many, out of every 100 patients that we treat with warfarin, it is fantastic if we actually can keep 65% of the people in therapeutic range all the time. And if you do that, the net population protection that you offer for stroke prevention in atrial fibrillation is only about 11%. That's a pretty dismal number. So as we got used to the usage of Coumadin, we also learned that it is very slow onset, and managing it from a therapeutic standpoint is very difficult. The very narrow therapeutic range makes it oftentimes difficult to work with it. And then there are variable and unpredictable anticoagulant effects, the genetic polymorphisms where somebody can have their INRs at 5 with 1 milligram, and then on the other hand, you have somebody else who requires 15 milligrams of Coumadin to have an INR of less than 2. How to really work with those people, and interactions with food, drug-to-drug interactions, and concurrent diseases. On one hand, you're telling your diabetic not to eat junk. On the other hand, you're also telling them not to eat green leafy vegetables. So how do you really balance it out? At some point, one of the cardiologists in Kansas City actually wrote a cookbook on how to manage your diet while on Coumadin, which may no longer be relevant with the NOACs coming into the picture. So all of those really sort of projected this image of Coumadin being a less relevant, more difficult to deal with. And that led to the arrival of the NOACs. I think after a decade and a half worth of research, after several trials and tribulations and initial failures, dabigatran came into the market as the very first novel oral anticoagulant that works very different than that of warfarin, with the promise of delivering the things that Coumadin was not able to do. So very soon, every company has had a drug in the reservoir, and they all rolled it out. And after 56,000 patient worth of studies, I mean, all of these were actually done in a very relatively short period of time. What I was amazed at when I looked at some of these novel oral anticoagulant studies was that the sheer number and the global nature of these studies and the heterogeneity of the population that they used in this is just amazing. The quality of the research, I think, has really gone up, because over the years, we learned that studying a drug in a handful of Caucasian patients that are limited to North America or Europe, it means nothing on the global scale. And that's the reason why these studies and these drugs that have been designed actually are more global in their perspective, and as a result of which the applicability of the science that we have from these drugs or from these trials becomes a lot more relevant to the global science per se. So we have the Rocket AF, the Explore, Aristotle, the Engage, all of these trials put together really rolled out and opened out the way for the NOACs, which clearly came out to be a strong contenders for warfarin in their overall improvement in the stroke benefit, especially the ischemic stroke, and a relatively lower incidence of hemorrhagic strokes, clearly establishing themselves as the way of the future going forwards. With that being said, the risk of intracranial hemorrhages is not trivial again. I mean, it's still around 0.3 to 0.8%, depending on which of the drugs that you look at, whether you're using a low-dose NOAC or a high-dose NOAC. And so if you put that into perspective, with these new agents, 80% of the eligible patients will be treated, and they will be therapeutic in their usage in about 90% of the time. Even with that, the net population protection that we can offer with the novel agents is still about 35%. It is a dramatic improvement from the 11% that Coumadin gives, but it is still not up to the par yet. So how exactly do you really balance the risk versus benefit? And maybe this is where the local treatments with devices really comes into effective role here. So that opens up another big question. So before you get too excited about it and want to offer these local device-based therapies, we probably should be able to risk stratify these people much better. And that brings us to the topic of who is really at high risk. How do we really say which one of these patients that you deal with atrial fibrillation, you should be thinking of putting them on anticoagulant versus those people where you should be talking about a more of a local device-based therapy like a left atrial appendage exclusion. So people who have ischemic strokes despite adequate anticoagulation, I mean, their INRs are 2 to 3 all the time, you check them, but they still have repeated strokes. And how do you really manage thromboembolism in patients who had previous intracranial bleeds? And many other categories of patients who cannot be on oral anticoagulations because they have GI bleeds, because they have other types of systemic bleeds, they're old, frail, they have Parkinson's disease and neuromuscular issues, and all of those really come to the forefront as we try to teach these people how to manage their oral anticoagulation. There are some staggering statistics that show that people who have the risk of intracranial strokes after intracranial hemorrhage is actually pretty dramatic. The risk of a second stroke after you have an intracranial hemorrhage is very high. So with all of these problems that are in front of us and our relative inability to take care of patients who have contraindications or repeated failed anticoagulation, we open up a new set of problems. Even the NOACs, as good as they sound to be in all these big trials, they still are not perfect. And we still bleed while being on NOAC, and we still have strokes while being on a NOAC, and perhaps the so-called assumed protective benefit that you have from NOAC compared to a warfarin may not really be as good as you think it is. So we have a study called the ROAD study where we're looking at when somebody fails or somebody has a recurrent bleed on warfarin, when you replace them with a NOAC, do you still have a protected benefit that we all assume that we have? And that doesn't seem to be the case. In about 75% of the patients who had a previous bleeding on warfarin, in about average of 13 days, almost all of them actually have a repeated bleed on a NOAC. And 10% of those bleeds would be from an organ that is different than what they have previously bled on warfarin. But in terms of the intracranial hemorrhages, it seems that there seems to be a protective benefit of these drugs compared to that of the warfarin. Only 24% of the people who had a previous intracranial hemorrhage had a repeated bleeding, and about 45% of the patients who had a systemic thromboembolization on therapeutic warfarin had a repeated event despite being on a novel agent in about 186 days. So again, the so-called NOACs are good from a management standpoint, but they do not provide us the absolute security blanket that we all want from these drugs. So let's roll on forwards a little bit with the left atrial appendage, where maybe the exclusion of the left atrial appendage is an important thing to talk about. The surgeons have done this for ages and ages together. They tried the sutures, staplers, cut and sew, a variety of different things that they have done. And now the world has kind of evolved more into a percutaneous left atrial appendage exclusion systems. You have at least 4 different systems that are available now. There are at least another 8 other technologies that are in various forms of trials in Europe and Asia, and some in North America. You have the Senjure plug, the Watchman device from Boston Scientific, and then you have the Lariat suture system, and then the AtriClip. They all have variable amounts of data. So you would think that by eliminating the appendage, you would take out the reservoir for the thrombus formation, thereby the stroke could be mitigated. You also perhaps decrease the overall incidence of arrhythmia and eliminate it, as a result of which your overall amount of arrhythmia burden would be lower, thereby contributing to less number of strokes. But all of these things have limitations in terms of the skill sets you need to possess, the tools we need to have, and then the individual anatomic variations that we really have no control over. And then at the end of it, who's going to pay for it? I think that's the biggest concern that will determine any kind of therapy at the end of it. So all of these factors taken into consideration, let's look at some of the data to show if the left atrial appendage exclusion actually works in the so-called high-risk patients whose oral anticoagulation is actually contraindicated. So this is a nice registry called the ASAP registry from Watchman, consisting of about 150 patients with a mean CHATS-2 score of 2.8. And when it is compared to a similar population with a similar risk score who are on anticoagulation or who cannot be on an anticoagulation, just taking Plavix alone, the relative risk reduction is about 77%. That's actually a pretty impressive number. And the same thing holds good even for the ACP. The data comes from a European registry where they found about 63% relative risk reduction in the overall incidence of strokes in these people. When you look at Lariat, the suture ligation system of the left atrial appendage, the expected event rate is about 6.2% for patients with a CHATS-2 score of about 2.3. By using the Lariat device, you can bring down that risk to about 1.3%. Again, that's an impressive risk reduction number. When you compare that to warfarin, I mean, you are looking at about a 1.3 to 1.7 reduction in the overall event rate on that. So with that, it's probably safe to conclude, based on some of the very preliminary data, that in high-risk patients where you cannot really give them oral anticoagulation, perhaps some of these regional therapies using either a Watchman or an ACP or a Lariat may be a very good option to think about where you don't really have many other options. Then can this concept be applied to global populations? That means anybody who is warfarin eligible, can you instead put in a device in these people and say that you're as good? And that, in fact, was what Boston Scientific tried to do with their Watchman device. You have the PROTECT AF study, which was one of the very early studies. That's a relatively large group of patients, about 463 patients enrolled, where they found that the primary efficacy endpoints were clearly met and they were non-inferior to warfarin. So, and when you look at the ischemic strokes per se, the overall number of disabling strokes are significantly better with the Watchman group than it is with the warfarin, whereas it's a wash with strokes that are less intense and severe. So when you pull up these local device therapies and compare them against the NOAC studies, they are very comparable, except for this one study called the PREVAIL, where the warfarin arm actually did much superior than the Watchman device, and all the statisticians are scratching their heads to really explain away how this is possible. But again, it's quite possible when you put somebody on warfarin and they're part of a clinical trial, the relative time in therapeutic range is going to be much better than it is in real life. So perhaps the Coumadin people actually did much better because you're actually providing them with superior anticoagulation. And when people are anticoagulated appropriately, they definitely have much better outcomes. So the combined meta-analysis of all of this very clearly show that these local devices are relatively efficacious in decreasing the ischemic strokes, and more so the hemorrhagic strokes actually are going to be much better. This is one big benefit that you get with the regional therapies than with the systemic therapies. And the same thing was actually replicated by ACP device with more than 1,000 patients from Europe, clearly showing that the local therapies have a role to play, and they are here to stay. With that, after a hiatus of about 10 years, Watchman device became FDA approved, and for the first time, we actually have a device that is available that is FDA cleared. And of course, we have the Lakkireddy device that we use that is used under the text of soft tissue closure. So the caveat here is the Watchman device is approved for all comers. It doesn't say anything about high-risk patients, and perhaps you probably cannot use the Watchman device at this point in time in high-risk patients, which essentially leaves open the surgical options and the Lakkireddy as possibilities. Before we wrap up, I would like to say a couple of things about the anti-arrhythmic benefit of left atrial appendage elimination. This is a paper that we just published in JACC EP called the LALA AF Registry, where we used appendage exclusion as an adjunct to AF ablation. All the patients actually got an appendage ligation ahead of time. 2 months later, we proceeded on to do AF ablation in these people, especially the persistent atrial fibrillation patients, where we found about a 25 to 26% improvement in the overall recurrence rates in patients who had the combined strategy compared to those of who had only AF ablation. And we also found that there is actually a small trend to show that there could be a potential benefit from systemic thromboembolization as well in the long term. And perhaps the volume reduction, and if you really look at the left atrial appendage as its own structure, perhaps the primordial embryological nature of the structure really explains a lot of the arrhythmic effects with the volume reduction, with the elimination of the triggered activity, re-entry that could happen in this structure, and also the downregulation of the renin-angiotensin system perhaps would help us explain away some of the overall reductions that we found in the arrhythmia burdens in these people, and that's something to really think about. So before we get too excited and start prescribing these local therapies for everybody, one has to be aware of the potential complications of these devices, the embolization of these devices, cardiac perforations, and the big learning curve that is ahead of us, right? So the skills for transeptal punctures and navigation and manipulation in the left atrial appendage, all of those are problems that we need to look at. And so when you look at the appendage elimination and compare it against Pradaxon, warfarin, there is a cost-effectiveness equation that reaches up there, and then these paths cross at about $50,000 US dollars, and that's something to think about. I think in the global picture, in high-risk patients, maybe this cost equation makes the most sense, but I don't think we can use these devices as a single treatment therapy for every atrial fibrillation that's out there in the world. So there are lots of very powerful, large trials that are available for NOACs, for warfarin, but the data for these devices is still very nascent. It's still coming up. I think we'll learn a lot more about this. So with those, it made into some of the guidelines on the European side, and we're making up some on the American side. These are currently a Class 2B indication, and especially in those high-risk patients, I think it makes the most sense. So for those patients who can be offered anticoagulation, that is a way to go. And for those patients who cannot be on oral anticoagulation and they cannot be on NOACs, obviously they would be good candidates for local therapies using the left atrial appendage exclusion technology, say the Watchman ACP or Lakkireddy. And I think this is something that we will be talking more and more about going forwards. And last but not least, this is one slide that I would like to show you. However you cut it, whether it is a systemic therapy or whether it is a local therapy, the triad of Warsaw has to be remembered and memorized all the time. What is it that you can do to prevent the endothelial changes? What is it that you can do to prevent the left atrial dysfunction and change the local and systemic factors? And perhaps primary prevention may play a much bigger role here. Effective treatment of hypertension, diabetes, relaxation techniques. Perhaps yoga has a place to play in some of these for those of us that have some interest in this. So with that, I think all of these therapies have a role to play depending on the potential risk profile of the individual. and their relative ability to tolerate an anticoagulant, you have to make a choice whether it is a systemic therapy or a regional choice, and preventing stroke forwards would be possible. With that, we wrap up, and thank you very much.